Hello, good evening, good afternoon, good morning to our global audience. I welcome you to this session on status epilepticus by the ILAE-Africa. Thank you for joining this webinar. My name is Nalucha Mwendeweli. I'm a neurologist from Zambia. Tonight, our speaker is Dr. Aisha Soni. Before I introduce her, I want to welcome all of you and then just a reminder of a few housekeeping things. So if you have any question or comment, please type it in the Q&A box during the presentation, and Dr. Soni will be able to attend to them after her presentation. So I had mentioned we have Dr. Soni. So Dr. Aisha Soni completed her undergraduate medical degree at the University of Witwatersrand in South Africa in 2014, for which was a recipient of the prestigious Vice Chancellorship for the duration of her studies. She then completed her neurology registrar training at the University of Cape Town and became a fellow of the College of Neurology, South Africa in 2023, followed by completing the Richard S. McLachlan Clinical Fellowship in Epileptology at the London Health Sciences Centre in Ontario, Canada in 2025, where she was a recipient of the IFCN Education Fellowship Award for 2024-2025. Her interest in research evidenced by 23 peer-reviewed publications and completed a Master of Medicine in Neurology through the University of Cape Town in 2022. So Aisha also has a keen interest in healthcare advocacy and human rights, which has earned her recognition as a recipient of a number of awards, including the Emerging Star Award at the South African Health Excellence Awards in 2025, American Academy of Neurology International Scholarship Award in 2024, and Advocate and Palatucci Advocacy Leadership Forum 2025, as well as being named as 100 Young Mandelas of the Future Leadership category 2018 and Male Guardian's Top 200 Young South Africans Health category 2027. Welcome, Dr. Soni, and I will hand over to you to go ahead with the talk. Thank you.
Thank you so much for the introduction, Alicia, and good evening to everyone. I'm excited to be here, and I hope that it's an interesting topic for you because I find myself very interested about status epilepticus. So when Nalucha approached me about possibly doing this webinar on status epilepticus, there are quite a few guidelines that we can actually read, but I think what I'm particularly interested in is how is status epilepticus managed in resource-limited settings. And this was actually a topic that I undertook in terms of research last year. And I thought it would be interesting for us to look at the results of that research and just go through it. And having been the first author on these two publications, I could give you some of the insights of what we found, which were quite interesting and may not have been always conveyed in the publications. So these were the two publications. They were both published within the last 9 months. And the first was the systematic review, which was in neurology. And this actually highlighted to us how there was a gap, and so we proceeded with an international expert survey, which was the second paper published in December last year. So to start with the systematic review and why we actually thought that it would be a good topic to address, as we all know, 80% of people with epilepsy live in low to middle income countries. And the mortality of these people with epilepsy is higher in these low to middle income countries, but also 2 to 6-fold higher than the general populations of these countries. And so it's a situation that needs to be addressed. And one of the main causes of mortality in these people with epilepsy is status epilepticus. So why is status managed so poorly, particularly in our settings? There have been quite a few papers written on this, and there are a couple of major barriers. These include poor healthcare infrastructure, lack of clinical training, lack of access to healthcare centers, poor connectivity and delays in transportation, intermittent availability of drugs, and economic affordability. And so this was just a rationale of why we decided to actually undertake a systematic review. So when we look at the treatment gap, and specifically the treatment gap of status is when it looks at the proportion of people with epilepsy who do not receive the appropriate and comprehensive treatment that they should be in our settings in low to middle income countries, it's more than 75%, whereas in high income settings, this is less than 10%. And if you go and do a PubMed search, you will see that there are lots of papers which identify these barriers, different settings, different continents, but there are very few solutions actually proposed in order to how address this. So within my own setting, I was a resident, and what I noticed is that even though we were a quaternary center in South Africa, we were still seeing a lot of morbidity and mortality associated with status management. And so it's a really big problem, and this needed to be addressed. And so solutions needed to be proposed. And this was the rationale behind us doing the systematic review. So we basically looked at how status epilepticus is managed in resource limited settings. This was how we did our research protocol, and we extracted articles from both EBBase, Medline, PubMed, and we also did the virtual health library, because the reason we wanted to do this is we didn't want to exclude any non-English articles, especially because a lot of resource limited settings aren't predominant English speaking countries. We checked all these databases, including LILACs, QMed, LIPEX, and up to September 2024. And the terms we used were status epilepticus, or convulsive or non-convulsive status, refractory status, super refractory status, low, middle, poor, limited, resource, income, or developing countries, and treatment management. And initially, we had thought that we would just focus on randomized controlled trials, non-randomized clinical trials, but we very quickly saw that if we didn't include case series, case control studies, and cohort studies, that we wouldn't be including a lot of studies. And so we actually included a very wide range of studies. So we actually, we screened 2008 records, and at the end, we were left with 23 studies. So this is a little bit just more about the inclusion and the exclusion criteria. I've already talked about the study types. We did decide after consideration to actually only focus on adults more than 16 years. And that number actually took a little bit of consideration, because within resource limited settings, we were seeing that publications were using the cutoff for adults as a vast range of numbers. Some people were saying 14 years, some people 18 years. And so we thought 16 years was the one that we came across the most commonly, and that it included the most number of studies. We then looked at various outcomes, and the most important was the termination of status, whether they progressed to refractory or super refractory status, and the MRI score, or death at discharge or follow-up within 1 year. And then what we did is, if, for example, an article didn't fall into this criteria, we still screened them. And if it was a mixed cohort of adults or pediatrics, we extracted only the adult data. And if we didn't exclude any non-English articles, so we translated those to English as well. And if there were articles that used both pediatric and adults, but they didn't have the info that we wanted to extract, we actually contacted the authors of these articles and tried to get that information before we excluded it. So we really went to all lengths to include as much as representation as we could. This was what we did in terms of data extraction. So we looked at general demographics. We then looked at the etiology of status as per ILAE guidelines, the type of status at onset, time variables, which is very important. But what we actually noticed a little bit later is that it's not always documented, and this included time to medical attention, as well as time to abort seizures. The diagnostics used, and this was specifically EEG, but also other imaging modalities. Then intervention details with regards to benzodiazepines, anti-seizure medications, anesthetic drugs, and additional treatment, and any outcome measure. When we looked at our quality assessment, the risk of bias, you can see that, so yellow is that there were some concerns regarding risk of bias, green is that there were no concerns, and red is that there were a lot of concerns. And you can see that quite a majority of the articles actually still fell within a risk of bias of having some concerns with regards to the parameters that we had predefined. So moving on to the results, out of our 23 studies, only one was from Africa. And what was shocking was this one was not even from any country in sub-Saharan Africa. So it was from Morocco. So not a single study on the management of status epilepticus has been published from sub-Saharan Africa up until September 2024. 3 were from Latin America and 19 were from Asia. 4 of these studies were randomized controlled trials, and the total sample size was around 1,526 patients. Out of these studies, only 2 focused on non-convulsive status, and there were 5 studies that focused on both non-convulsive status and convulsive, with the remaining all focusing only on convulsive status epilepticus. So when we looked at the etiology of status, acute symptomatic accounted for 21 to 88%, which is a very wide range, But we tried to include that range just to give a representation of how wide the data was actually represented. And then the second most common cause was non-compliance to anti-seizure medications, which went from 0 to 54%. This is just a summary of the papers we actually looked at. So you can see Africa, there was just that one paper from Morocco. Asia, there were quite a few papers. They were the highest number, so 19, with a lot of them coming from India and China. And then we also had some from the Philippines, Iran, and Turkey. And then we had only 3 from Latin America, 2 from Peru, and 1 from Honduras. And you can see that the larger numbers were actually from the papers in Asia as well. So a lot of representation from Asia when looking at this topic, but very little from other resource limited settings. This was a representation of what I previously mentioned, so the etiology of status, and acute symptomatic, which is that dark blue color in all of the papers, was the commonest cause, followed by non-compliance, which is the orange, and then some of the other causes, which we went according to the ILAE guidelines, were far less common. Now, time variables. So in every single status guideline, we like to emphasize that time is brain. It's very important. You need to manage status as quickly as possible. And yet this was very poorly documented across all the studies. In fact, only 5 out of the 23 studies actually assessed time outcomes, and the results were really mixed. So 4 studies reported times less than an hour. So out of them, time to medical attention ranged from 2 minutes to 24 hours, which again is a very big range. And time to abort seizures was 1 minute to a week. They say that one study even reported that it took more than 3.5 hours, and that this was associated with a high risk of death or loss of cortical function, while the other 2 studies found that a delay in treatment was not even associated with mortality. So the risks, the outcomes or the results regarding time were very poorly documented, and we couldn't really get any definitive answer. In terms of diagnostics, and this is where we really focused, because we wanted to see what do you do in resource limited settings where you don't have access to EEG. In South Africa, for example, we have EEG routinely available at one quaternary center, but we don't even have continuous EEG. And so what do you actually do in these cases? Again, it was very poorly documented. 5 studies only had access to continuous EEG, and these were all from Asian tertiary level high centers. 9 studies had routine EEG on at least some patients, and 9 studies, despite their topic being status epilepticus, didn't even mention EEG. The one study, so there were 2 studies done on non-compulsive status. The one study had no access to continuous EEG and just relied on routine EEG and clinical assessments. In terms of treatment, we looked at first-line treatment, which is a benzodiazepine, and 15 studies said that they either gave it alone or in combination with an anti-seizure medication, and the most common, and that was phenytoin in all cases. And the most commonly used was diazepam in 8 studies. It was used at that dose, but it was inconsistently repeated and not really said whether it was. And we know in status guidelines that the benzodiazepine can be repeated twice, so it really wasn't given. IV lorazepam was used in 5 studies, and then a number of other studies used combinations of either IV midazolam, oral clonazepam, or multiple benzos. In terms of anti-seizure medications, by far the most commonly used is valproic acid, which was used at a decent dose, so that was reassuring to find. Followed by IV or oral levetiracetam in 13 studies, then IV phenytoin, and then phenobarbital. So interestingly, oral anti-seizure medications are not uncommonly utilized, and these included topiramate, carbamazepine, oxcarbazepine, clobazam, and clonazepam. They weren't used as first line, but they were documented as add-on therapy. And because there was such a wide and varied use of anti-seizure medications, we couldn't draw conclusions regarding outcome measures. So initially, we had decided to do a meta-analysis as well, but the results were just so varied that we weren't able to do that, and there weren't enough randomized controlled trials. This is just a visual representation of the benzodiazepines used, and diazepam is the orange, so you can see it dominated, and it's the most commonly used one, followed by lorazepam, which is the dark green, and then the multitude of others. This a table we did, and this basically showed the anti-seizure medication, how many were used, and then the outcomes. But because the outcomes weren't documented routinely, we couldn't actually draw any solid solid analyses from what anti-seizure medication was used in regards to the outcome. And so we just landed up actually documented what was being used. And this is just further of the other 23 studies. So out of the randomized control studies, we had 2 studies which said that they found some benefits of using phenobarb over valproic acid, and 2 studies which found no significance between valproic acid, phenytoin, and levetiracetam. In terms of outcomes, the 19 studies said that there was death in up to 42.6% of patients, but patient characteristics were very heterogeneous. And then an MRI score of 3 to 5 was documented in 10 to 50, up to 59% of people. And obviously, they noted that there was an increased risk of mortality associated with refractory or uncontrolled status. So overall, we could only draw limited conclusions regarding this. So coming to the discussion, what we concluded was that the treatment of status should be guided by protocols, but the implementation of this is very poorly implemented. And this isn't just in low to middle income countries. So there was actually a systematic review recently published as well, and it looked at 16 international clinical practice guidelines published on the management of status. This was actually in epilepsy, and the authors concluded that the recommendations on general management were fragmented. And so it's not just within our settings. Overall status isn't managed well, but it has a much bigger impact in our settings where we have a much higher incidence of epilepsy and much higher incidence of people with epilepsy having mortality from status. We also found that there was a paucity of literature from Africa and on the use of continuous EEG, that there were very wide and heterogeneous practices, and that local availability often guided what was done instead of the guidelines. And so people, what they were saying in their papers is that they were using what drugs were available to them, even if it wasn't on the proposed guidelines. In terms of etiology, we found our findings were in keeping with other papers. So an acute symptomatic cause and infectious cause is commonest in these settings. And so this is just used to guide appropriate and timely investigations from the onset. And then non-compliance to ASNs can be attributed to a lack of education, culturally based stigma, poor access to healthcare, and limited access to affordable treatment. We know that if you use a continuous EEG, you are likely to detect 80 to 95% of non-convulsive status, whereas serial intermittent or routine EEGs only detect 45 to 58%. Despite this, we still saw that majority of centers actually didn't have access to continuous EEG, and didn't not just have access to EEG, but also the personnel to conduct these tests. And so what they were using is clinical assessments. So they were looking for clinical signs, and these could be subtle and not always easily to see. And then they were also using periodic routine EEGs. With regards to benzodiazepine use, we know that if convulsive status is longer than 60 minutes, you actually have a higher risk of resistance to first-line benzodiazepines. And this obviously leads to a higher risk of progressing to refractory and super refractory status. Despite this, 70% of patients are still underdosed with benzodiazepines, and this was congruent with our results as well. And again, diazepam was the most commonly used. So what we saw is availability actually dictated use, and that even though in most guidelines it recommended that benzodiazepine be repeated, this wasn't done consistently. Anti-seizure medications was the most surprising for us just because it was so remarkably heterogeneous. Phenobarbital, which isn't mentioned routinely in some of the guidelines, was still used in a lot of these settings, and it has a general tolerability, rapid and long-lasting action, and a favorable safety profile at high doses, and it's very cost-effective. So in China, we saw that it was still the first choice. And then another interesting one was topiramate, because it was actually used quite a few times as add-on therapy, and this is an oral option. And even though it was a late treatment option, we couldn't assess its standalone efficacy because they didn't really say it was an add-on option, and so you couldn't really say how it worked on its own, but it is a cost-effective option and was used. And then we were unable to draw outcomes, and mortality is higher than reported in low to middle income countries. So we have up to 20% of mortality from status. So the strengths were that we had quite a comprehensive search strategy, and that we also included non-English studies. But the limitations were that a lot of the time, even though we were getting representation from, say, from Asia, it was in the quaternary centers. So we were only having very specific regions that were actually represented. Some of the papers focused on specific patient populations. So there was one paper that only focused on elderly people. There was another one that only focused on pregnant ladies. And so it wasn't really a good representation again. And a lot of the time, the studies were done with retrospective review of clinical records. So what we concluded is that status in low to middle income countries is diagnosed and managed in a widely heterogeneous manner, and it's often led by local practices and drug availability. Studies from Africa and Latin America remain very limited. We still know that the commonest etiology is an infectious one. In terms of first-line treatment, benzodiazepines are still being underdosed, and in terms of second-line treatment, anti-seizure medications, especially the older drugs, are more favored, and oral anti-seizure medications are not uncommonly used. And if you look at all of the very common or the very popular status guidelines today, you'll hardly ever see an oral anti-seizure medication included on there. And then lastly, lack of access to continuous EEG monitoring was a uniform barrier. So moving forward, we realized that there were some barriers that had to be addressed: the doctor-patient ratio, poor health infrastructure, and affordability of ASMs, and delayed presentation times. But again, these have been documented and it isn't new. And so we thought to ourselves, what can we actually do that's pragmatic and can actually lead to a process going forward where we can improve outcomes for our patients? And so we realized that we actually need clinically appropriate status guidelines for low to middle income countries. And this is what we thought our next research step should be. So because we don't have enough information, so when you want to do guidelines from a systematic review, you would need level A evidence to actually draw proper clinical guidelines, or it would be a modified Delphi process. And so because the discussions about a modified Delphi process were still ongoing, we decided in the interim to do an expert survey. A survey, while it doesn't hold a lot of research value in terms of on the ladder of how important it can be, you can actually gather a lot of information from it. And so what we decided to do is that it would be a mixed method, so quantitative, which would include thematic analysis, and this would give people the opportunity to give us free text answers, so that it wasn't just about clicking and what we decided the barriers were, but people could actually communicate what they're experiencing within their settings. And we had 76 questions in total. We also decided to do a purposive sampling of senior clinicians. So we know in resource-limited settings, while in an ideal world, it will be the neurologist or the epileptologist who's managing status, a lot of the times in our settings, we don't have the capabilities for that. And so it's the emergency, in South Africa, it will be the emergency medicine department who will be the initial ones who actually manage it. It will be the intensivists or the critical care who don't necessarily have a neuro background who are managing it, and then the neurologists. And so what we did is we actually invited clinicians from all three of those disciplines because we wanted to know what their experience was. In the end, we actually had 28 experts from 15 countries and 4 continents all join, and they represented all of these specialities. And a majority of them had more than 12 years clinical experience. A lot of them were tertiary level clinicians. We invited heads of clinical departments because we actually wanted that clinical experience to come through in how they managed it. And then we try to get global representation. So this is a choropath of who we invited. We actually invited more than 40 up to 50 participants, and then we only had 28 who responded. And you can see that sub-Saharan Africa was really targeted, and that was very distinctive. We did that because in the systematic review, we had absolutely no representation from them. We then also went according to Asia and the population over there, and we try to include the Middle East, North Africa, and then North American countries as well, and try to get a representative view from all of these countries. So what were our findings? I found the findings fascinating, and I really enjoyed having all of their perspectives. The number one core finding was that the guidelines don't fit. So only 25% of respondents felt that the existing status guidelines are applicable to them. 96% agreed resource-specific guidance is needed, and that high-income country assumptions limit feasibility. So we basically asked, and they all agreed with this. The second core finding was that medications drive care. And again, this is what we found in our systematic review. So they were saying what they were experiencing in the clinical care, what we found in the research as well. So that they were administering anti-seizure medications according to what was available and not necessarily what was recommended or what has been shown in the research is actually shown to be the best option. There was no consensus on second-line agents, which was also very interesting. So we found that even though all of these senior clinicians and experts could recognize what the problem is, no one actually agreed on what it should be. So even though they were saying, I'm using this, and another person would say they're using this, no one agreed on what they should be using. And then there was strong support for oral anti-seizure medications when IV was unavailable. Again, this isn't mentioned routinely in any of the main status guidelines that we have. Phenobarbital is a viable option, and that pragmatic substitution when ideal drugs are absent is not something that can be avoided at times. Moving on to diagnostics. So we looked at EEG specifically. Less than 40% had routine EEG access. And when we say routine EEG, that doesn't mean just with the ability to do a routine, but actually having access to an EEG machine and the capabilities to do that. Continuous EEG was rarely available. And there was and so that pie graph represents how the availability actually scattered across these clinicians. So 50% said it was available, but with delay. 39% said it was routinely available, and then smaller percentages said not available at all. Again, what we noticed is that despite everybody recognizing this as a limitation, there was no agreement on what should be the actual limitations. So we actually gave them options. We said if continuous EEG isn't available, then routine intermittent EEG should be done and an option was every 4 hours, every 6 hours, every 12 hours. We didn't get a clear answer from everyone. We also said, how long should this routine intermittent EEG be? Should it be 30 minutes? Should it be 60 minutes? Should it be 20 minutes? And no one actually, we didn't get a clear answer. The results were too scattered. So serial EEGs in the free text answers were described as imperfect but necessary substitutes given our settings. Then we looked specifically at education gaps, and the key results was that status is rarely discussed at routine epilepsy visits. So these were clinicians who were actually looking after patients with epilepsy, and they were not discussing it with them. Home seizure action plans were very uncommon, and there was a strong consensus for caregiver education, pre-hospital training, and benzodiazepine use before hospital arrival, although there was agreement amongst the group that this hardly ever happened within low to middle income settings. So what did we actually agree on that should happen? Because I've highlighted that there was a lot of agreement on what isn't available. There wasn't really agreement on what should be the answers or the solutions, but this is what clinicians did agree on. So high consensus priorities were that resource-sensitive status guidance should exist. There should be clear transfer criteria, and this box on the side is actually something we drew up from what everybody agreed on, and it was almost 96 to 100% that they all agreed on this. So the minimum standards for monitoring outside a tertiary center should be those parameters. The reasons to consider transferring to a tertiary center were those, and then the standards of care prior to transfer included airway management, supplemental oxygen, established IV access, and adequate benzos given and loaded with an anti-seizure medication, as well as hemodynamic stability. They also agreed that education should happen across all levels of care, both from pre-hospital care to primary caregivers, as well to primary healthcare personnel all the way up. And then telemonitoring and remote expertise was something that came across very strongly. So this was an option that we gave in the quantitative questions, but it also came across in the thematic analysis of the qualitative responses that a lot of these clinicians thought that telemonitoring could be a helpful expertise in managing status. And then multi-center registries amongst all of us is what was regarded as something that should be done going forward. So what exactly is being done next? So looking to the future. So everybody agreed that we should have guidelines that informing guideline adaptation discussions. And this is a very sensitive topic because it was brought up by quite a few of the respondents, and it's also something that we as a research group discussed afterwards. We do not want to adapt guidelines where we are giving our patients suboptimal care. Because we know what the level A evidence says, we know what the level A evidence says should be happening. And so we don't want to be proposing substitutes that are going to actually disadvantage our patients. Instead, we want to promote substitutes that could be good. So there should be research done that these could be equitable or equal to what is being proposed in high income countries, but is not available to us. Or we want to promote or work more towards this being available. And so working in a resource limited setting, I know that this isn't always possible, but what some of the respondents said is that we should be very careful about falling into a trap where we say, okay, this is what is acceptable for our patients, even though the level A evidence says that this is not good. They supported a registry development. And so that's something that we're very keen to do. So basically getting together a registry, collecting data. And like we saw from the systematic review, which actually laid the foundation for what we need to do next, there isn't enough good quality evidence on what actually is happening. And so if we have a registry, that's actually a coordinated effort, and then we can actually put everybody's experiences together in a tangible way in terms of collecting data and then move forward from there. We should frame this status as a system level emergency. So a lot of them said that it should be taken to their healthcare systems or how their health departments within their countries, and it should be recognized as the emergency that it is. And then all of this was aligning with the WHO IGAP priorities. And so that's exactly what the WHO IGAP is about. So these were the conclusions, and what we found was interesting is that we carried out the international expert survey expecting to find more answers. And so we had found what the barriers were in the systematic review, and we thought talking to these senior clinicians, we would actually get the answers to what is meant to be done or what is being done in terms of routine intermittent EEGs or anti-seizure medications. But what we actually found is, while everybody does agree these are the problems, we didn't necessarily find the answers that we were hoping for because there wasn't agreement. And so it just emphasized that going forward, we actually need to work together, and we need to work coherently in terms of registries, in terms of having that discussion, so that what we put forward is actually plausible for all of our patients. Thank you. So that was just an overview of what we did in terms of status. And I think I went through that quite quickly, but then it leaves some time for questions if there are any.
Thank you so much, Dr. Soni, for that presentation. So please feel free to share any questions in the Q&A section, and they shall be answered by Dr. Soni. Just to start off, Dr. Soni, the challenge, like you've highlighted, of course, is one of the things is availability of medication in resource limited settings. And of course, we have these guidelines that are showing medications that are not readily available. And I've seen from your presentation, there's still the use of phenobarbital, which in most settings, that's the one that's widely available. My question would be for those that only have phenobarbital and will use the phenobarbital in first line, what option do they have for second line? Oh, that's where they'll really you repeat the dose before they go to third line.
Yeah, so phenobarbital was actually quite a large part of our discussion because, like you said, it's available in a lot of countries. In China, it's still the first choice. And I mean, you would think that China actually has access to, or they had quite a few studies in the systematic review. So they're actually publishing on it, but they're still using it a lot. And it's actually a very cost-effective option. We found one review that actually focused just, that was recently published and just focused on the use of phenobarbital and status epilepticus and highlighted that it's still a very good option. So I don't think we should put phenobarb to the side. I mean, we do have our studies that compared valproic acid, phenytoin, and levetiracetam, and they were shown to be efficacious, but phenobarbital is still a very strong contender, and I really think it's something that should be used after having done the systematic review, and I can see that it still is being used. Now, in terms of second line, I guess it would be whatever's available. And this is where we actually saw in the systematic review that a lot of countries actually then resort to oral options. So we were seeing after phenobarbital, if they didn't have any other IV options, carbamazepine was being used. But like you know, you can't do a loading dose with carbamazepine. So it was just one big dose that was being given. Even topiramate was being given. Clonazepam, which is actually a benzodiazepine, was being given as the second line anti-seizure medication. And so this is also a consideration going forward for any status guidelines, which oral anti-seizure medications actually have value and can be added to guidelines so that they can be applicably and well used within these settings. And that was just something that we actually saw when we were doing the systematic review, that oral ASMs are not out of the picture when it comes to status, and it's still widely used.
Okay, thank you. I think I have a comment from Zaiton Shivji. Intermittent EEG recording is now more commonly used instead of or when continuous EEG is not an option. What's your
So
comment?
that is true. I think that's probably true, and that's what we got from the International Expert Survey. So we didn't get that as a result from the systematic review, but that's what a lot of clinicians were saying that they were doing in their practice. The thing that nobody agreed on is what parameters do you actually use for serial intermittent EEGs? And if you look at the literature, there isn't a lot on this. So there's maybe two randomized controlled trials, both of which have been done in high income countries regarding routine serial intermittent or routine EEGs versus continuous EEG. And there's no real specification about what duration should you be doing, how often should you be doing it in a day in order to give you similar results. And while it is still being used, we still have the stat that if you're in non-convulsive status, continuous EEG will identify that non-convulsive status up to 90%, whereas routine EEG is only up to 40 to 50%. So it definitely is not as ideal as continuous EEG. Yes, everyone's using it, but then what parameters do we actually use? And there isn't a lot of literature published on that. The experts, the clinical experts couldn't agree on what actually should be used. And so I think that's an area of interest for future research and something that can really be focused on, because if we can actually recommend in terms of the parameters, duration, frequency of serial intermittent EEGs that could be comparable to continuous EEGs, it's a real gap in order to improve outcomes.
Okay, so another question is, did you get the percentage of patients with status epilepticus that didn't respond to the first and second line and had to be admitted at ICU for anesthetic agents?
We did, so there wasn't a clear percentage. It was more like a lot of the time ICU wasn't available, or for example, if they didn't have an ICU, then this patient was being intubated and booked and managed in the emergency department, which is why we decided to include emergency physicians within our international expert survey, because we saw how much of the time that they were actually managing these patients. But in terms of outcome measures, our specific outcome measures were actually progression to refractory or super refractory status epilepticus, which was not consistently monitored. And then what was more commonly monitored, recorded, I should say, was actually MRI scores, either at discharge or follow up at 1 year. And that was either MRI scores or death. And so that was what the outcome that we got. Again, we couldn't really draw conclusions from our outcomes, either with regards to progression to refractory status that needed to go to ICU, or outcomes in terms of how the patient did once they were discharged, because it was so heterogeneous. And this is a point for future research for anybody within resource limited settings. If you're going to be doing research in status epilepticus, those are good parameters to use for your outcome measure, because that's what's commonly being used. And so it would be a good measure to use for future research.
Okay, so pre-hospital management is ideal. How available is buccal midazolam? Time of status onset defined at 5 minutes for buccal midazolam is pre-hospital or in hospital where no IV access is available. Whilst not your primary question, what were your findings for managing at the time of onset of status where outcome can be improved?
So it wasn't our primary question, you're right, but it was actually one of the questions that we looked at in the systematic review in terms of time. And what we noticed is that time was not consistently actually recorded. So again, that time was quite wide. So time to medical attention ranged from 2 minutes to 24 hours. And so that's quite a wide range. But one study actually said that it took patients 24 hours to actually get their first benzodiazepine. So it was really, really wide. I think from my experience and from what the clinical experts said, it can also be very variable. It depends on transport availability, it depends how close you are, whether you're close to a primary or secondary level center, whether you're closer to a tertiary level center. It also depends a lot on the education of the pre-hospital personnel. And so this was another thing that all the clinical experts agreed on, that we should be focusing a lot of our efforts on education, and specifically education at pre-hospital personnel, because we know that the longer that you don't get a benzodiazepine, the more likely you're going to be refractory to status treatment. And so if you can get in that benzodiazepine, and pre-hospital personnel or even caregivers are treated, are educated to give that benzodiazepine earlier, then we will see better outcomes. In terms of buccal midazolam, from the people that it was actually an option. So we actually gave a whole host of benzodiazepines that could be available to the clinical experts, and it was not routinely available. It wasn't one of those that was actually available more commonly. I know in South Africa we don't have it routinely available, so it's not that easy to get.
Okay. Another question. Did you look at brain imaging as well?
So yes, we did look at brain imaging. So in the systematic review, we looked at whether what it was used, and that informed a lot of the etiologies. That's how we actually found out that it wasn't always explicitly stated what the etiologies were, but a lot of the time when we went back to the MRIs, we could see it was an acute infectious etiology, and we could then classify it. In terms of asking the clinical experts, we did ask them how many of them had access to CT or MRI, how many of them would have access to that within their centers, how many of them would have access to a radiologist who could actually report on that, even if it was after hours. And the results were quite low again. So even if some of them, and a lot of them, because they were they were clinicians and head of the departments, they did work in tertiary level centers that had radiology access, a lot of them wouldn't have radiologists who could actually report on these. And so again, it was a lack of access. It wasn't as alarming in terms of lack of access like EEG was. So it was a little bit more available, but not as much as EEG, but it was still a barrier. And MRI was not even something that was easily available. So then we also asked them, if you had access to CT or MRI, is it available within the first 24 hours, within the first week, or after a week? And most of the answers were within the first week, so not even within the first 24 hours of status management.
Okay, and this one, status epilepticus patients of more than 60 minutes become resistant to which anti-seizure medication?
That would be the benzodiazepines. So there was a paper done, and they actually measured how if different times of when benzodiazepines would be given, and it was found that if the benzodiazepine is given even more than 60, more than the longer time, so up to 60 minutes later, then the mortality and the refractoriness to benzodiazepines went up to more than 80%.
Okay. So would you think that having mobile EEG labs to conduct routine EEGs is beneficial? In addition, there are lots of talk about take-home seizure monitoring or seizure recognition technologies. Do you feel that having affordable seizure monitoring systems for patients in low middle income countries is an option, especially for patients who are in high security risk areas?
So that's a very good question. And yes, it's my personal opinion, but actually it was also brought up in the qualitative answers. So when we went through the thematic analysis for what is the answer to the lack of EEGs, a lot of the clinicians actually said that they think the answer is you get these portable EEG systems, you get these ones that are actually more affordable in terms of you being able to hold them, and there is research in it, so it wouldn't be like the routine EEG, but it's more like a mobile system. And then AI also came up, so you get these AI EEG systems where you don't even necessarily need a human to actually detect whether you have epileptiform activity. So when we looked into the discussion for how available this would be, again, all of the research that is published on these, so like for example, the AI systems or the remote or the mobile EEG labs or the remote telemonitoring is really done in a lot of high income countries. And I'm not sure how available they would be, but if it is something that we can see as a potential option, I think it's a very credible solution. And that was what the experts thought as well. The take-home monitoring, seizure monitoring, was also mentioned by the clinical experts. And again, it all fell under that umbrella of the AI technology, or basically not relying on an epileptologist or a neurologist to read the EEG lifetime or an intensivist, but on other ways that we can use technology in order to identify these rhythms.
Okay, so in most resources limited areas, access to critical care, ICU, is also limited. What effect did it have on the management of cases in these areas and their outcomes from your study?
So agreed. From the systematic review, we actually recognize that ICU care is not available and it's often not routinely available, and that patients who needed management in an ICU setting were either getting this within emergency departments or even sometimes in the ward because there just wasn't enough ICU beds, ICU personnel. So in terms of what management outcomes it had, I mean, we found in the systematic review that the outcomes were overall bad, but we couldn't link that specifically to there not being ICU beds. So then, when we did the international expert survey, we actually asked the experts who manages status within your settings, and it was almost hardly ever the ICU. It was hardly ever the ICU consultant. A lot of the time, it was the intern or the medical doctor who's rotating there, and we asked them who was the primary doctor who's managing it. So it was hardly ever the intensivist or the neurologist. Maybe it was the intern doctor working in emergency medicine. The emergency medicine physician was very common, and undoubtedly this would lead to poorer outcomes. If we have to be pragmatic, though, and this was brought up in the discussion with the qualitative replies, it's not like we're going to be able to train a whole lot of ICU intensivists or neurologists over time. And so that's where it linked back to education. And so a lot of the experts said that if you actually educate the primary or the secondary level healthcare personnel who also have a lot of lack of education when it comes to status epilepticus management, then you can actually, they think that's where you would actually be able to see better improved outcomes. And so it should be that these status guidelines are actually targeted to them within their settings, and so that it can be applicable to them as well, because it's not like we're going to increase the ratio of neurologists to the population in all of our settings overnight. That's going to take a lot of time.
Okay, so another question, what are some gaps in data available in Africa for status management? Among them, which of them would you recommend as low-cost surveys for independent researchers?
So, in terms of, if you could just leave that question there, because I think it's two parts in the literature.
Oh,
So I'll just,
yes, it's okay. So the first one is what are some gaps in
yes.
data available in
So
Africa for status management?
certainly the most important one that we noticed was EEG use. So I think like the first question was that we are most commonly using serial intermittent EEGs, but then we aren't publishing on how we're using it. What are our outcomes when we're using it? How frequent are we doing it? Is it being interpreted as it's done, or is it being interpreted later? Is it used to inform clinical decisions, and how? So I think EEG is really, really a big gap in the literature. And then the second one was the anti-seizure medications. And it shouldn't just be about local availability, but perhaps a little bit more structured. And that would be more just not for specific regions, but it would be across regions. So it could be something that could be looked at in terms of research from that perspective. And that's what we actually thought would be our next steps in the research process, bringing together all of these clinicians and all of these representatives, and they wouldn't just be tokenistic, or it wouldn't just be about having representation, but it would actually be about them signifying and being symbolic in terms of what's actually going on in the ground, and then making recommendations that are both good for the patients but also feasible. And so in terms of what low-cost surveys for independent researchers, I don't, in terms of surveys, I don't know if that would add any more benefit at this time. There's a lot of research into what the barriers are, and I think now we have to look at what the solutions would be.
Okay. And next question, is there any evidence of the use of rectal diazepam in pre-hospital setting for prevention of status epilepticus?
Mhm. I don't know of any evidence specifically, but it is something that I can go read up, and I could perhaps let Clement know if I could get his details. But I'm sure that rectal diazepam can be used. I know that the big studies actually haven't compared rectal diazepam, say, for example, to the oral or the buccal formulations of midazolam or lorazepam. But because diazepam was the most commonly used, it was most commonly used as an IV formulation, which is likely related to its cost effectiveness. I am sure that the rectal option could be an option, but I would have to go and read on that specifically.
Yeah, I think what I have is rectodiazepam for use as rescue therapy for those who are having like seizure clusters. Um, Maybe not really preventing, but then, seizure clusters, if you give rescue therapy, it helps in somebody not progressing to status. So probably
Yes.
this is in relation to what the person is asking. Um,
Okay. I just don't know its efficacy in comparison to the other formulations and other benzodiazepines, whereas there have been some studies that have shown that, for example, certain formulations are comparable to each other.
Okay, one more question. In a case of a male child who is on epilim syrup and lamotrigine tablets and once a week experiences status epilepticus, what is the best treatment?
So that's a little bit of a difficult one without the context. What I can say in terms of status uh, epilepticus management overall is in order to prevent it, you should probably always try to optimize the management. So the first thing that I always do in my practice is I always try to optimize the doses that they are and get them to the maximum tolerable doses of the medications they are on. And then if someone is only on two anti-seizure medications and they're having frequent presentations of status, add-on therapy is never a bad option. And so you can always add on other anti-seizure medications as well. But always try to optimize. A lot of the times in my practice, what I see is a patient who's on a lot of different drugs, but none of them are at the optimum dosage. And so I guess the first step is always try to optimize what you're on.
Okay, so another one, bucomidazole is perhaps something that should be presented for inclusion in the WHO IGUB to be added as essential, as more bioavailable when administered than using oral anti-seizure medication, and can be administered by untrained non-clinicians. As you said, oral anti-seizure medication was something that is not considered in high-income management. Perhaps there's no evidence of effectiveness in the context status. So I think this is a comment and not really a question.
Yes,
Um,
but I actually agree with that comment. So the first thing is yes, like the reason that we undertook this research and any future steps we're going to be doing is so that we can make recommendations based on good level evidence that is actually good for our settings. So baclomodazolam then might be a good option. And then I also agreed with the second part of that statement about it being I don't remember, but I agreed with that we should
yeah.
include it. Yeah.
Okay. Next question. Even though levetiracetam was proven non-superior to phenytoin in the Eclipse trial, would you still recommend it, given it proposed good side effect profile as a second line?
Yes, certainly. So levetiracetam, valproic acid, phenytoin, you'll find all three of those recommended in nearly every status guideline. And like you said, in the Eclipse trial, not one isn't better than the other. So either or, whichever one you have availability can be used. Levetiracetam has a very good side effect profile, and so it can be used. But the limiting factor with levetiracetam, though, is its cost. So especially when it comes in its intravenous formulation, it can be quite costly. And so that's why a lot of centers in resource limited settings will actually opt for one of the other two. And so valproic acid was the one that we found was most commonly used in the systematic review. And then the other thing is never to forget phenobarbital, because even though it isn't on the guidelines, it has been shown to have a good side effect profile when it's been used in these settings, and it's very cost effective.
Okay, so I think this is our last question. I'm not sure if you're going to take it. What is the loading dose of IV levetiracetam in a child with status epilepticus?
So I'm an adult epileptologist and we did focus only on children, but I do know that the loading dose in general is 40 to 50 milligrams per kilogram. And so I don't know if that is applicable for a child as well. Any pediatric, you could correct me, Nalucha. I'm not sure.
I think I have to check for a child as well, but I'm sure if you check you could find the loading dose. That was the last question, but I'm seeing more questions popping up. I think maybe I can just take one more so that we can close in time. Uh, What role can the government of low middle-income countries play to help alleviate the limitations and challenges involved in treatment of status epilepticus, most especially in ICU cases? And the second part is, what's the best strategy to apply to ensure inclusion of all the necessary stakeholders?
So I think this is the most important part, like of our jobs that a lot of the time gets overlooked, and that's actually advocacy. Because as much as we are clinicians, we also advocates for our patients, and so a lot of the time we have a lot more power than we actually think we have. And people in government won't know the challenges that we're facing if we don't actually bring it to them. So something that I'm very passionate about is status and epilepsy surgery, but one of the things that I do is advocate a lot for epilepsy surgery. And once you actually start telling people what the barriers are, what it can actually do, what the benefits are, and I think the same goes with status. If you start saying, these are our mortality rates, this is our morbidity, this is what can, with a simple measure of, for example, making IV levetiracetam available, this is what we could see in terms of better outcomes, you will see that people in management, people in government, and it would start at hospital management and then government, would actually be very amenable to this. So I think it's actually a lot of the onus and the clinical responsibility actually falls on the clinicians. And that's just within every region. If we had people advocating for the appropriate management and the appropriate availability and access to what we need for management, this could be taken all the way up to the government level. So just an example, a good friend of mine, Cleo Rubens, they actually managed to get continuous EEG at one of their hospitals. And it just took a lot of advocacy, a lot of education, and a lot of actually pushing that agenda. And in the end, it's always just for the patient. And it's just about a stepwise approach. And I've seen it in action as well in my epilepsy surgery initiatives.
Okay. Thank you so much, Dr. Sonny, for the presentation and the wonderful interaction, Q&A interaction. There's still some questions, but I think we have to end on time. Thank you for everybody who joined us this evening. So just before we go, I'd like to let everyone know about the Global Health in Epilepsy Project database. So this provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding resources, and volunteer needs. So this database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. So this database will provide you with an opportunity to learn from others and to also explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, nonprofit, or philanthropy to learn about existing efforts while offering a means to engage. So on the next slide, please scan the QR code to receive your certificate. There's also a link in the chat box now for you to access your certificate. Once more, thank you to everybody who has joined us. For those whose questions and comments were not addressed, I apologize. We're running out of time, but thank you so much for your participation. Thank you, Dr. Sonny, for the wonderful presentation this evening. Have a good night.